When 1 year of no contraception, they have lived together and still they haven't conceived. That's the time when they have to see a gynaec.
One thing is that ultrasound, as the name suggests, are basically just sound waves. There's no mechanism for it to harm a pregnancy. People often confuse it with radiation.
Only sexually active women need regular gynaec checkups.
Absolutely a myth.
The most common things what women are advised to avoid are papayas, pineapples, for no really good scientific reason. You can have them in your normal quantities.
Yeah, I feel at least there are 2 to 3 times in life where I would think a girl or a woman should go to a gynecologist. One is when a girl gets her first menses.
Hi, I am Jagu and welcome to a new episode of the Good Doctors podcast by Zynova Shalby Hospital. Gynaec health is often talked about in fragments, a symptom here, a phase there. Today's episode looks at it as one continuous story. With Dr. Parikshit Tank and Dr. Ritu Agarwal, consultant gynecologists and obstetricians at Zynova Shalby Hospital, we'll cover how women's health evolves across life, from periods and contraception to pregnancy planning, surgery options, immunizations, and the myths that quietly shape our choices. This is about understanding your body better and not second-guessing it. Let's get into it. Dr. Agarwal, Dr. Tank, thank you so much for being with us. Much appreciated. Let me get right into it. And I'm hoping in the course of this episode, we will learn more about gynecology, pregnancy, endoscopy, far more than we know now. But let me get some basics right. There is always a feeling that a woman should only go to a gynecologist if there is a problem. However, there is a process where one would say that even if things are normal, some sort of checking is required. What are the parameters for that? Nothing is wrong, but should I go see a gynecologist?
Yes, definitely. I feel at least there are 2 to 3 times in life where I would think a girl or a woman should go to a gynecologist. One is when a girl gets her first menses. Then it serves a lot of purpose because, she gets to know how to manage her menses, that it's normal. She gets to know about vaccines. She gets to know about really if there's anything wrong with her body or any abnormalities are present. Second time, I would say a preconceptional checkup is very important because the woman is going to plan for pregnancy once she's mentally ready to accommodate another, member into their family. Then they should go for it because it gives them a chance to know if they are medically, there is any abnormality or if they already know there is anything, to optimize or to change the medications according to the pregnancy. There should be infection screens and there should be, of course, there are any problems with the reproductive organs as such.
Fair.
So they get prepared for it and about vaccinations also.
Fair.
And the third time I would say is when she's approaching menopause. Know about, because cancer screening and all that becomes more relevant at that time.
I hear more and more conversations happening about perimenopause. So ladies in their 40s, is that fair to assume? So at what stage should one start talking to a gynecologist? Perimenopause or well into perimenopause, when you believe you're about to hit menopause or you're just sensing it? When is a good time to start that conversation?
So perimenopause is obviously a very broad frame of time.
Yes.
Because we don't know when exactly menopause happens.
Fair.
For an average, you can say that a woman in India will have menopause somewhere between 45 and 50.
Yes.
That itself is a broad range. And then if you take a few, standard deviations before, after, that's really a decade that you're talking about.
Absolutely.
So I would say that probably once a woman crosses 40, then you are in a good enough time frame to see a gynecologist as a baseline.
Okay.
And if everything is okay, probably the good doctor will tell you to not come back for a while or will call you back annually.
But you make an important point over there that even if everything is good, you still want a baseline.
Yeah.
So if there are changes, then you have something to refer back to.
Absolutely. I mean, that kind of sets the tone for the years to come.
Bilkul. Dr. Agarwal, let me ask you this. Even when you see patients and they've come to you for the first time, is there a question or two that women are hesitant to ask, but really, honestly, that should be amongst the first questions that they should?
Yeah, many a times, women are, especially in our country, they are very, they feel like certain things are taboo. They should not talk about it. So they are hesitant about, sometimes even about vaginal discharge. Or more common in our country, they are more hesitant to talk about their sex life or a low libido or pain during intercourse or something. These are things they are very hesitant to talk about.
Fair enough. But if you feel that there is an anomaly on any one of those fronts, those are questions that you should immediately ask.
Definitely. They should discuss it out and they should come out with it so that they get a solution for it.
Fair. And there are solutions, no doubt.
Yes,
so you have to ask the question first.
Yes.
Absolutely.
Same way about leakage of urine also. Women are very hesitant. They keep it to themselves for a long time. Jabki it's a very common thing after menopause or something.
But they would do that even when talking to a professional, even when talking to a doctor?
For a long time, they are hesitant in going to a professional itself.
Yes. Okay. Fair enough. Dr. Tank, let me ask you this. Preconception care has now, there is more and more conversation about it. Even the WHO now has guidelines for it. How does it, when should they come to you? Because usually we are pregnant, we should go see a gynecologist. But would there be something to be said for even when you're thinking about it, go see a gynecologist?
Absolutely. They say that well begun is half done.
Fair enough.
So if you begin planning, then you're well on the way to the right path to achieve the goal of a healthy family.
Fair.
And preconception counseling allows us an opportunity to do just that. Get the woman in the best possible shape, get the man in the best possible shape, and then they go on and have a family.
Absolutely.
More relevant for the woman, of course, but I think we shouldn't forget the man in this equation also.
Sure. Fair.
There are a lot of lifestyle issues which can be corrected to, promote sperm quality, fertility, so on and so forth for both the partners. And then specifically for the woman, because she's going to carry the pregnancy,
yes,
we screen her for infections, for certain health conditions, including thalassemia, for example.
Okay.
And that ensures that, not everything, but close to everything gets covered before they embark on this journey. So WHO has now made it a standard of offering this to everybody, a universal proposition.
Okay.
And I think we should follow that.
Fair. And, Dr. Agarwal, on the flip side, there is the whole preconception care, but there is also the philosophy, and a lot of us follow that. It will happen naturally. Now, sometimes that takes too long, but then in that thing of it will happen naturally, no need to see a doctor, there is sometimes too long of a gap.
Yes, exactly.
What is the ideal point? I mean, sure, you're not going to conceive at first try. Often enough, that will not happen. But when should they start seeing a gynecologist?
Exactly. This is a very well-defined question.
Okay.
So when a couple is living together and that is without contraception, so at least for a year, if they have lived together, and means, of course, if a man is living abroad and they have not spent time adequately, even that has to be taken into account. So when 1 year of no contraception, they have lived together and still they haven't conceived, that's the time when they have to at least start investigating, and they have to see a gynac to know, because lots of things come up. There are reasons if they have not conceived during that time.
Fair. Okay. And
Jaggu, just a small addition to what Dr. Agarwal has said. I think this is the standard textbook definition, which is published and accepted worldwide.
Okay.
But I think, in urban India, more and more couples are starting to plan a little later in their lives.
This is true.
So if you have a couple where the woman is over 35 I might be a
Start
little
earlier,
more
yeah.
aggressive in terms of starting investigations or
agree.
some basic treatments.
Okay.
Agreed.
So maybe for younger than 35s, 1 year is good. I mean, that's sensible so that you don't get into their lives too much as a medical professional.
Fair.
But older couples, maybe 6 months might be a reasonable cutoff where they should at least get evaluated.
Fair. But then there's also something to be said of, well, the one absolute green flag is then contemplate preconception care.
Yes.
Don't even do the waiting of 6 months, 12 months. Ideally, that's what you want to do. But if one has not done that, then we have timelines of 6 months for people over 35.
Because girls are getting married at 35, 40 now. So this is a very common scenario.
Fair.
Very relevant.
Fair. No, I can imagine. So when a couple is pregnant, in the first trimester, khas karke, there's a lot of myths. Grandmother's advice, or we thought grandmother said this, so we should be doing this. What are these? Tell me, there are many of them. Top 3 myths that need to be busted.
Number 1 is food. I mean, the taboos and myths that surround food in the first trimester are absolutely mind-boggling.
Fair enough.
The most common things what women are advised to avoid are papayas, pineapples, things which are citrusy, for no really good scientific reason. You can have them in your normal quantities.
Fair.
For these substances, for these foods to actually cause harm to a pregnancy, they would have to be consumed by the kilo. And even then, they might not necessarily harm anything at all. So I think probably the number 1 myth is food related. Maybe number 2 could be ultrasound can harm the baby in the early part of pregnancy. One thing is that ultrasound, as the name suggests, are basically just sound waves.
Sure.
And sound is all around us.
Fair.
There's no mechanism for it to harm a pregnancy. People often confuse it with radiation, which comes from X-rays and CT scans.
Yes.
Sometimes X-ray clinics have all these facilities, and that's why probably the impression might be there that ultrasound is somewhat linked, but it's just not.
So it's a lack of specific knowledge more than it is.
Absolutely.
And nowadays we do those transvaginal ultrasound. Where the probe, it gives us better information when inserted through the vagina and in the early pregnancy. So, they feel like it will directly go and harm the pregnancy. So they come and share it with us also that, ऐसे किया तो कुछ हो तो नहीं जाएगा.
But then at least they're asking the question so you can clarify it immediately.
Yeah.
So those are the myths. But let me flip it on its head. Sometimes there are early warning signs that couples, women ignore because they think that they're normal. Or at least they tell themselves that so they can avoid a doctor's visit unscheduled. What are those early warning signs that women should look for, couples should look for?
Yes. You mean the early pregnancy signs?
In the first trimester, yes.
So, sometimes, there is a spotting or something which couples experience during the first 3 months of pregnancy, early pregnancy. So they think it's normal, aisa to ho jata hai. But it's really not something which should be ignored. Even a single episode, it should be investigated. Because there can be missed abortions, there can be pregnancy which is not in the right place, like it's called an ectopic pregnancy. It may be in the tube. Or if they experience any dizziness, too much of dizziness, abdominal pain which is not subsiding, it could again herald something like a ectopic pregnancy again, which should not be ignored. It could be an emergency. Or even a fever or any kind of symptom which is persistent and is not going away, it should not be ignored in pregnancy.
So persistent in terms of a pregnancy would be a week or
persistent means
longer?
Sometimes there's a fleeting pain, but it's not subsiding at all. So these should not be ignored, like a fever or anything like this. It should not be ignored at all in pregnancy.
A generation or two ago, when they say it takes a village to raise a child, and joint families or even just relatives living close by, more and more that is not the case. So for, say, a nuclear family, working woman, there's lesser time for self-care, as it were. There's enough on her plate. What are the 3 non-negotiables they should work with irrespective of what their schedule looks like?
Okay. So just to quickly enumerate the top three, I would say meal preps, exercise,
Okay.
reasonable amounts,
Okay.
and don't miss your doctor's visits.
Okay.
So just to elaborate a little bit, meal preps, I mean, avoiding totally ready-made meals and
Nice.
processed foods.
Okay.
By exercise, I don't mean everyone's got to spend 2 hours in the gym or something. Even 20 to 30 minutes of physical activity done consistently every day for at least 5 to 7 days of a week.
Okay.
That's brilliant.
Fair.
And doctor's appointments, because certain things run on a schedule. I mean, if you miss, say, for example, the 12-week scan and the marker test which goes with that, then that's an opportunity which is lost at that point of time.
Fair. It's a tracking opportunity.
Yeah, exactly.
Okay. So let me, Dr. Agarwal, with you explore this physical activity thing, that it is recommended, but is there a minimum or a maximum?
Yes.
So like Dr. Tank said, at least 20, 30 minutes in a day. Can we assume that is the minimum, and therefore what is the other extreme?
Okay, I would say 20 to 40 minutes of moderate exercise.
Okay.
Like walking, light aerobics. Something like this would be okay. But anything which, causes too much of abdominal pressure or very, heavy weight lifting or very, very high impact exercises or contact sports, these should be avoided, definitely.
Okay.
And some kind of exercise is necessary because it prevents a lot of complications. It helps with a lot of medical conditions to keep them away.
Fair. I want to move on to the subject of endoscopic surgeries. I mean, it's a technology that's almost life-changing in certain circumstances. But here's the thing, it is newer, but it also comes attached with the word surgery. And once you hear that, there is a mental turn off, as it were, or a mental hesitation. How would you describe the advantages of an endoscopic surgery in the case of gynecology, pregnancy?
Okay, so I mean, endoscopic surgery, let's discuss about it in the non-pregnant state, because 99% will be in the non-pregnant state. So the biggest advantage of endoscopic surgery is a faster recovery.
Okay.
Probably less pain and resumption of your day-to-day routine earlier as compared to an open surgery.
Fair.
So these are the top things that would attract me to offer endoscopic surgery rather than an open surgery to somebody.
Okay. So Dr. Agarwal, what are the most common problems that can be solved endoscopically, where then we can safely avoid the old open surgery thing? What are the most common factors there?
The most common things for which surgery is done is, one is infertility, of course. When a couple is not able to conceive, you want to directly go in and look as to what the problem is with the reproductive organs. And rather than, open up, endoscopy is a very, very good option as a fertility enhancing surgery. Of course, everything else, otherwise, like fibroids or ovaries which have cysts, ectopic pregnancies, everything can be tackled endoscopically these days.
Okay. Yet there is, and I'm coming back to that original thing of that it has the word surgery in it, one way or the other. And so there is that hesitation. When someone is pulling themselves back from an endoscopic surgery, there are no doubt side effects to that. I mean, what is that? Is that fertility? Is that quality of life? Is that recovery? What are they missing out on, or what are they getting themselves into by avoiding even an endoscopic surgery?
So I'll take this question a little broadly, that what happens if you avoid surgery which is necessary? First, let's look at that, and then let's go to endoscopic surgeries. So, I mean, normally a good doctor will advise you surgery when it is probably the last resort sort of thing. In that situation, delaying or avoiding surgeries could have detrimental effects, such as, say, for example, somebody who has heavy bleeding and we've tried everything else, nothing's working, needs a surgery.
Fair.
So she could land up with a situation where the hemoglobin or the blood level falls so low that she might actually need a blood transfusion or even an admission to an ICU.
Okay.
So it could be an extreme consequence of that sort. It could be something which is not life-threatening, but life-changing. In the sense, sometimes a small fibroid inside the uterus may be the only thing which is preventing a couple from getting pregnant.
Fair.
And they're not getting it removed.
Fair.
So that becomes an obstacle. That becomes a block
Fair.
to a life-changing journey. So things like that. Now, let's come to the sub-question of endoscopic surgery. It's a no-brainer. I mean, if you can do something with smaller incisions, faster recovery, less pain, why would I bother to do that with a bigger incision and keep the woman for a longer time in the hospital?
Fair.
In fact, just a response to what you asked earlier about what can be done in gynecology through endoscopic surgery. I think we should turn that question around now. What can't be done?
Is that right? Okay.
It's become like that. There's hardly anything that we can't do endoscopically.
So technology has progressed in that direction.
Yeah,
Except
hugely.
the cesarean, I think.
Maybe ovarian cancers or
Ovarian cancers,
extremely large tumors. Fine. Okay. But pretty much almost everything else, it's possible to tackle endoscopically today.
Okay. No, and point well taken. I wanted to go back to a point that you made about fibroids. A lot of women, without being diagnosed or perhaps even knowing, choose to not do anything about it because it is not creating an immediate large issue. But no doubt there are consequences to avoiding treatment or even diagnosis. What are those? I mean, what are the consequences we're dealing with?
Yes. So we, means left and right, we see fibroids creating all kinds of problems. First, it starts with, they can cause infertility itself, that the couple cannot conceive with that. Many a times, they come with heavy bleeding, especially if the fibroids are more towards the inside of the uterus.
Got it.
And sometimes they cause extreme pain because of their size or because they could undergo torsion on their own self. Sometimes there could be sepsis, in the sense infection also can occur with fibroids. So they can present, and they can present with a large mass if ignored for a very long time. We see patients coming with almost, like a 9 months pregnant uterus, even that much.
Wow.
So even that happens. So these are the various ways in which fibroids generally present.
But shouldn't a mass that big have, that you
Yes,
can
sometimes,
literally physically see it, should have been a red flag well before?
Sometimes, they just feel that, I'm aging and, I'm putting on weight or something like that.
Okay.
So,
and let's not forget the power of deluding oneself.
I can do
living
that
in
very well. I see what you're saying.
The second thing is procrastination. We'll go to the doctor. Not this month. Now it's,
Next month.
New Year's will come. Then we'll go later.
Yeah.
And later. And later. And then, by the time we sometimes see them, it's really late.
Wow. Wow. Does every fibroid need surgery, or can it be worked with a first let us observe or medication and then surgery? Or is it just best to eliminate it via surgery?
No, I think most fibroids will not need a surgery.
Okay.
A few women with fibroids will need a surgery.
Okay.
So, by far and large, which sort of fibroid would I be considering as a surgical target? It would be fibroids which are causing significant complaints to the woman.
Okay.
If they are very close to the uterine lining and causing problems, if they are preventing a pregnancy from happening, if the fibroid is growing, especially if it's growing fast,
okay,
and if it has certain unusual features on imaging or certain blood tests, then those are the fibroids that I would recommend a surgery for.
Okay.
Now, typically, those would be about 20 out of 100, which I would see.
I see.
80 women, I'm just going to say, okay, there's nothing really significant. Wait and watch, come back for an annual review.
Okay.
So,
let me put it to you this way, and I'm taking that thought further a little bit. the complication or the confusion of how will fibroids affect a pregnancy. Are there ways to resolve the fibroid issue without affecting fertility?
Yeah, fibroids can at every stage, they can affect pregnancy in the sense that they can prevent a couple from conceiving.
Sure.
Because of their presence, because they can prevent the fetus from implanting. They can prevent they can prevent from the conception also. Plus, they can cause, once the woman has conceived with a fibroid, they can be the cause of an abortion, an early termination of pregnancy, the baby not growing. So they can be a cause of recurrent abortions also.
I see.
And at the time of, say, suppose the woman carries herself to term with the fibroid, then at the time of delivery also we can experience problems. That, the labor process itself may be disrupted. There can be excessive bleeding because of fibroids. And suppose we take her up for a cesarean, that can also be challenging at times.
I see.
So these are the challenges which the fibroids can pose at every stage of a woman's life.
But I ask this as a layperson, once fibroids are treated, does the treatment itself affect future fertility, or is the problem solved?
Yeah, so fibroid surgery is getting better and better.
Okay.
But it has the potential to cause something called adhesions.
Okay.
Now, these adhesions are usually, eliminated by good surgical technique. But they can happen. I mean, even with, best of precautions, one may get adhesions.
Okay.
The ones that we are concerned about are when adhesions in the pelvis go on to block the tubes on both the sides.
Okay.
Or inside the uterus. I mean, if the cavity of the uterus was opened during a surgery and the walls of the uterus go and stick to themselves, then those are problematic sequelae after a fibroid surgery.
I understand.
The other thing that we need to talk to younger women about is the chance of recurrence. Of, I've removed one fibroid or two fibroids, but 5 years down the line, there can be another fibroid which the uterus generates.
Sure.
And this recurrence cannot be prevented by any sort of surgery.
Okay.
So those are the two things that we need to kind of keep in mind and offer surgeries for fibroids very carefully. I mean, with due process in mind.
Okay. What Dr. Tank said about there could be a recurrence, but fibroids itself, we've seen generationally are more prevalent now. Does that have to do with lifestyle choices? Does it have to do with the kind of food that we eat? What is it, and therefore what should we take care of?
Yeah, to a large extent, how a fibroid occurs is a complex thing. There could be genetics into it. There can be environmental factors. There can be lifestyle factors which go into it. So the genetics part, of course, we have no control over. But a sedentary lifestyle, anything, which causes hormonal disturbances can promote the happening and the growing of fibroids. Like, more vibrant use of OC pills these days, and early menarche, polycystic ovarian diseases, because that is a condition where there is an excess of estrogen.
Okay.
So,
but again, no control over that.
Yeah. No. Because, it is again promoted by a sedentary lifestyle.
Okay.
Smoking, obesity. These are the things which contribute to, excess of fibroids, which we see all around us these days.
Okay.
So these are definitely contributing to that. And of course, now we have better methods, imaging methods, more availability of medical care. So they are getting detected also.
Fair enough. Okay. Those are, one, easier detection, but two also.
But yeah. They
bad lifestyles that can be improved.
Of course, it can be improved. Yeah.
Fair. I want to move on to vaccinations, immunizations. We think of it as something that we do as children and we're done. But for adult women especially, there are vaccinations and there is pretty much a timetable. Am I mistaken that one should look at? Can you just run us through that?
So one is, the general adult immunization, which is now becoming totally mainstream. As you rightly said, earlier when we were training, probably immunization was restricted to the pediatric age group.
Fair.
And children's doctors.
Okay.
They were the people who were in
Who
charge
used
of
to
the
carry
vaccines.
vaccines.
Yeah.
Fair. Yes. Huh.
But today, there is a well-defined role of adult vaccination. For example, hepatitis B. In case it's missed out or one does not have immunity to it, it is recommended now. Plus, there are ones which are specific for women, which includes the HPV vaccine, or what's popularly called the cervical cancer vaccine.
Yes.
Which has become very much in the news in the last few years.
But there is some hesitation about it even now.
Absolutely.
But tell us more about that. Should we be, is there some reason to be hesitant, or actually we should just go ahead and do that?
Right. So the reasons to be hesitant about it are not very well founded at all.
Okay.
I mean, a lot of it comes from social media, which is not evidence-based at all. It comes from rumors.
I'm waiting to see what part of social media is evidence-based. I see very little evidence of that.
Maybe this one. So a lot of, coincidental things have gotten linked to vaccines.
Yes.
And they are blamed for some totally unnecessary outcomes. So we know for a fact that HPV vaccines, for example, have been used literally in millions of women without causing any significant harm in the long term, with the provision of at least an 85-90% reduction in the chance of cervical cancer. So that's a huge thing in terms of cancer prevention.
So, it's called the cervical cancer vaccine, but it's actually a vaccine for more than that. The HPV vaccine is broadly covering what? I mean, cancers and other issues also. Can you just run us through that so that we have some medical clarity as far as the HPV
it covers you against cancers, the cervical cancer, vulval cancer, and it also covers you for warts.
Okay.
And let's not
warts.
forget the boys. I mean, in countries like Australia and New Zealand, it's like a universal program. It's not gender related.
Oh, because I just assumed that HPV vaccine was for women.
No, it's for the boys also.
Okay.
Yeah. It prevents penile cancer.
Penile cancer.
I see.
The same virus, the HPV virus, does cause all these cancers.
But that gets decided at a national health level about whether it's going to be for across genders or just women.
Very true.
Okay, fair enough.
Now there's an Indian vaccine also. So they are coming up, they're trying to even further reduce the cost so that it's available universally for the girls. Because it's one program which can be very successful because the cause of the cancer is known now.
Yes.
So the government is trying to work into it.
Are there vaccines that are specific to pregnancies? It helps with the health of the mother and the baby. Is there a timeline for that around the time of a pregnancy we should
I would also like to talk about the rubella vaccine, which we recommend in girls before pregnancy. Of course, live vaccines are not allowed during pregnancy, but that should also be given to girls besides the HPV vaccine. And during pregnancy, we recommend the typically it's called the tetanus vaccine, but it should be the Tdap now. The tetanus, diphtheria and pertussis, which covers the woman as well as the neonate.
Okay.
The child is also protected against it. And of course, the COVID-19, if it has not been given, even that can be given during pregnancy. And the influenza vaccine, which comes every year.
Yes.
That is also given. It's optional, of course.
Okay.
But
is there a good time of year to be taking the influenza vaccine? Should it be just before the monsoons or just before?
It's recommended. Every year a new strain comes up. So they recommended it during that time before the monsoon start.
Okay, fair enough. Because for in Western medicine, I think it's before winter. But that doesn't count for us. We're better off the
viral
South
illnesses
Asian...
in our setup is, I think, in the change of the season, the monsoons.
Fair. Okay.
Just to complete this, I mean, if you missed it, doesn't matter. Just take it when you get the opportunity.
Fair.
And that would often be the case for pregnant women. You don't know which season you're going to become pregnant.
Fair. Yes.
So don't bother. Whichever is the current strain, the clinic will generally keep the most updated version and they'll administer it to you. So,
no, valid point. I mean, let's not wait for one more year.
Exactly. I mean, you'll miss the boat.
Yeah, that's perfectly
procrastination.
That is very true.
At least take it.
Yeah, no, absolutely. I want to come to contraception. It's people are willing to talk about it more now, which is a good thing. Plus, probably needed more now. Lifestyle changes and all of that. Is there a one size fits all type of contraception, or is that from a women's health point of view, we need to look at it from an age perspective, lifestyle perspective, geography perspective? How does one look at this?
So, in terms of contraception, what we talk about is the cafeteria approach. I mean, it's called that.
Okay.
And essentially, it involves offering a number of things to a couple, which are safe and feasible for them, and then letting them make the choice. It's like going to a restaurant and looking at a menu. Okay, these are good for me, and out of these, I'll pick this.
Okay.
So yes, based on all those criteria which you mentioned, age, lifestyle, so on and so forth. Just to give you a simple example, I mean, typically contraceptive pills, not the emergency contraceptive pills, the regular ones. The regular contraceptive pills, we tend to avoid for women who are 40 or over, especially if they are on the higher side in terms of weight.
Okay.
Similarly, for somebody of that sort, maybe a Mirena, which is a device which goes into the uterus, might be the perfect choice. Because she might have heavy bleeding issues also.
Fair.
So, it all depends on the age, what they want, and also the medical condition, what they might have along with the need for contraception.
Dr. Agarwal, let me come to you with a specific question. Hormonal contraception. What is that? What are the side effects? Does someone have to then make a choice about, okay, I should switch out of this or switch into this? How does that work in particular?
Yeah, hormonal contraceptive, or commonly the form which we use it in is the pill. So this has the estrogen and the progesterone typically. So the common side effects which we see with this are very commonly nausea, vomiting, bloating, some kind of weight gain, puffiness and all. So these are small, but when you really come to women, they will not like it and they'll just stop using them.
Fair, yes.
Or sometimes, some women, they have a tendency for migraine headaches. And very commonly, we avoid it in families which have a history of thromboembolism or something. It's a condition where, they have a tendency to make clots.
Okay.
Or where they have a deranged liver problem.
Okay.
So those are the places where we avoid it. So the common side effects are these.
Okay.
And sometimes, they have bleeding problems with this. While they are taking it, there can be breakthrough bleedings. And they have less periods sometimes. Even that, sometimes girls, women, they may not like it.
Fair.
So these are the common side effects.
The good thing is that, if a woman persists for a couple of months.
That's where I was coming to, yeah.
And tides over this initial period,
phase.
Okay.
They often have time for their bodies to adjust to this pattern. And they are able to take it for a long, long time.
So one does persist for at least a couple of months. It's not like it didn't work for me right away, so I'm going to stop using it.
Yes,
absolutely. There is something to be said to keep
and
it going for
luckily we have little low dose pills. The original OC pills, they had very high doses.
I see.
Nowadays we have very, very much better products which have lesser side effects.
Fair. I want to come back, Dr. Tank, to the point that you made about emergency contraception. It's being more misused nowadays. Is that a fair statement to make, or not?
I wouldn't call it misuse, but I think it is occasionally misdirected.
Okay.
What happens with emergency contraceptive use is, first of all, couples expect it to be perfect or near perfect, like a usual contraceptive method. Modern contraception offers couples 98-99% protection, whereas an emergency contraceptive pill, even if it is taken in the way it is supposed to be taken, offers somewhere around 70%. So there's a gap over there straight away.
Okay.
The second issue is that it does result in a little bit of an irregular bleeding. And the worry which has been expressed even by other doctors is that repeated use is going to throw the cycle out of pattern. But again, it's temporary. If a woman were to use it, say 2-3 times in a month, at the most, what will happen? Her period will get a bit irregular for a month or two. That's about it. But if she does that and consults a gynecologist, that's a wonderful opportunity for us to offer her much better things than only an emergency contraception.
And that would be the correct way to use it. The efficacy is not as good as other forms of contraception.
True.
So you want to be careful about that.
Yeah.
You don't ideally want to overuse it, but if there is reason to use it and then see a gynecologist.
Yes. True. Absolutely perfectly put.
Okay. There are myths that lead to unwanted, unintended pregnancies. Like it's not, they don't even medically pass muster. But can you go over some of these myths so that we recognize them as myths and not as medical advice?
Yes. Many couples use a safe period method. They consider that, immediately after the period or before the period, that period is absolutely safe. So that is not valid all the time because, sometimes the ovulation time may vary or something. So it's not a method which should be regularly followed, the safe period method.
Okay.
Plus, some people, they are used to using a natural protection. They will not discuss also. They will say, okay, hum apna naturally protect karte hain. But a pull-out method or something like that. But that's also not 100% safe. A common myth which we see is that lactation period, how much ever time, you will not conceive. This is what women think. But even that is not true. Because at a variable time, the ovulation comes in again.
Sure.
So they will conceive. And this happens so many times that women come back with pregnancies during the lactation period. Okay. So these are certain myths which lead to unwanted pregnancies.
Okay. There are other myths and truths that I want to explore almost as a rapid fire. But before we get into that, there is one question I did want to ask. If a woman wants to take control of her gynecological health today, what is the first small step that she should make? Literally in the next 7 days, what should she do? First small step.
So if she's over 40, I would recommend 2 very simple things for her to do. One is get a pap smear and a visit at a gynecologist clinic.
Absolutely, I agree with you.
And the second is get a mammography or a sonomammography done.
Okay.
So these 2 things at a bare basic from the reproductive health point of view.
Okay. And this would be an annual thing then, or at least that's your starting point and then the gynecologist will tell you what to do next?
Jagu, I wouldn't say annual, but I would say periodic.
Okay, fair enough.
So depends on what's found on the initial baseline and then what's the age of the woman, any background risk factors, so on and so forth.
Okay, fair enough. Would anything you'd like to add to that, Dr. Agarwal, from a immediate care point of view?
If you say 1 or 2 things, and this is absolutely right.
This is the way to go. Okay. Now, I want to move on to the concept of myths versus, is it a truth, is it a myth? I'm going to throw it at you all. Any one of you all feel free to answer, just so that we can clarify this once and for all. Irregular periods always means a serious hormonal problem.
Not really. I would take that question. In the extremes of life, when a girl is starting to get her periods or towards the end when she's approaching menopause, it's really, it happens with most of the women that they have irregular periods.
Okay.
So it's not really abnormal. But of course, anything which persists for a longer time you should go to an expert and get yourself checked.
Fair. Okay. The other one is painful periods are just a fact of life and one just has to live with it.
Yeah, unfortunately, this is a myth. I mean, occasional periods may be painful. They may be painful for a few months, especially in the beginning of when menses start. But if they are persistently painful and the pain is getting worse, don't accept this as a routine.
Okay.
Have an evaluation, and there are plenty of pain relief methods besides surgery, which can safely be offered.
Okay.
So don't suffer.
Fair. Okay. Their options are there.
Yeah.
Okay. Heavy periods after the age of 40 is just a fact of life.
Yeah, 1 or 2 periods towards, as I said, there are hormonal changes after around the menopause time. So there can be heavy periods, 1 or 2 heavy periods at that time. But I would absolutely say this is a myth, because even a single episode of excessive bleeding or an irregular bleeding after 40, 45 should be investigated, because we left and right see cases where we find even malignancies with such things. And we detect a lot of things when the woman has actually thought that, okay, ye to normal hai. And there are neighbors to tell them.
Yes.
There are their friends to tell them, अरे ये तो होता है. इस वक्त तो चला जाएगा, जाने वाला है, इसलिए ये ऐसा होता है. So this should not be ever done. Even a single episode needs evaluation.
Stress doesn't impact fertility or the menstrual cycle.
Oh, tough one. I mean, theoretically, stress does affect reproductive hormones.
Okay.
But then we are looking at extreme stress.
I see.
What normal people face on a day-to-day basis is usually not sufficient to disrupt either ovulation, menstruation, or getting pregnant. So to blame the fact that periods are irregular and I'm not getting pregnant because of my work stress, that's probably not an accurate assessment.
Okay.
There might be something else in the background.
Fair. And reason enough to therefore have it checked out.
Yeah.
Absolutely. Home pregnancy tests are unreliable in early pregnancy.
I would say it's a myth, because home pregnancy test should be done rather. And if it's properly done, it gives you a diagnosis.
Okay. Properly done being the operative phrase over here. Okay. And if periods are regular, everything inside must be healthy.
No.
Okay.
The heart may be beating, but there can be a heart attack at some point. So same way, women may be getting periods. They might be regular too, but it's not a guarantee that everything is fine.
Okay.
It's a great signal. I mean, I'm not denying that fact. The regularity, the usual menstrual pattern, if it's maintained over a long time, does indicate that this is probably a green flag. But,
system is running.
Yeah, the system is running, but don't take it for granted.
Okay. So annual testing is still important.
Yes. Periodic testing would be recommended. Yeah.
Absolutely. Periodic testing is the word to look at. Only sexually active women need regular gynac checkups.
Absolutely a myth. Because besides sexual activity causing problems, they can be, as we have discussed, there are so many other things which are, not because of infections or not due to sexual activity. There are fibroids, there are so many conditions.
Daily lifestyle is creating triggers, as we've seen.
So many. Rather, that is more important, I would say.
Okay.
So that's not the only thing which can cause. So it's a myth, definitely.
Okay. And that brings us to the end of a very enlightening interview. Thank you so much for this, Dr. Tank, Dr. Agarwal, for taking out your time and doing this. We're very thankful for your time. Much appreciated.
Thank you.
Thank you very much.
We also enjoyed.
Good health decisions come from good information and good timing. If something from this conversation felt relevant to where you are right now, let it guide your next steps. Our thanks to Dr. Parikshit Tank and Dr. Ritu Agarwal for the clarity and perspective that they've brought us. See you in the next episode. In the heart of Mumbai stands a name trusted by thousands. Over 1 lakh heart procedures, 200 plus years of combined experience. From diagnosis to recovery, your heart gets complete care under one roof. Because when it comes to your heart, experience isn't optional, it's everything. Zynova Shalby Hospitals. Experience you can trust, care that you deserve.